Hi. Good morning. The meeting of the Baltimore City Council Public Health and Environment Committee is now called to order. I am Councilwoman Felicia Porter, representing the 10th District and Chair of the committee. In attendance, we have Councilman Mark Conway from the 4th District.
Thank you, Madam Chair.
And also Councilman Ryan Dorsey from the 3rd District.
Thank you, Madam Chair.
Before we get started, please take a moment to turn off or silence your cell phones. Today the committee is holding a hearing on 2 council bills. The first hearing is Council Bill 25-0013, Child Health, Equitable Access to Health Services in City Schools. For the purpose of addressing disparities in child health by expanding access to comprehensive health services for children across Baltimore City, including well child preventative care and vaccines, family planning services, and dental services, providing for a referral to a vision or mental and behavioral health specialist at the written request of a specific individual, requiring mandatory follow-up care for any positive or abnormal health screenings, defining certain terms generally relating to expanding access to health care for city students and school health centers, and providing for a special effective date. First, I want to thank my colleagues in attendance today and acknowledge everyone that has worked hard to bring this hearing together. I want to also thank our witnesses and those who will be providing testimony who have taken the time to share their expertise and experience with us. Most importantly, I want to thank the parents, teachers, and health professionals and community members who have been fighting year after year to give Baltimore's children the care they deserve. Right now in our city, there are children who are struggling to learn because they cannot see the board in their classrooms. There are children in pain because they have untreated dental issues. There are children suffering from mental health challenges with nowhere to run. And there are families, good families, who are doing everything right, working hard, and trying their best, but we as the system are failing them. This is completely unacceptable, and this is considered a health crisis. Because every child, no matter where they live, no matter their family's income, deserves the right to grow up in a healthy, strong, and an opportunity environment to succeed. We know this, we have known this, but knowing it is not enough. We are here today because it is a time to act. We have a responsibility to fix what is broken, and that's exactly what the Child Health Equity Act does. This bill ensures that no Baltimore child is denied the health care that they need. When a child can't get medical care they need, that is not their fault. This is our fault, and this is the failure of our leadership. But let me be clear about something else. Leadership is about what you do next. And we cannot undo the past, but we definitely can influence the future. We cannot change the years that children have suffered under this broken system. And today is an opportunity for us to make sure that we not only provide a system and environment for them to thrive, but that we use all of the tools in our toolbox to ensure that every child, no matter where they are in the city, have an opportunity to learn and a responsibility to act and a commitment to our city. Thank you so much, and we'll get started with remarks from the Health Department.
Good morning, Madam Chair and the members of the committee. My name is Francine Childs, and I'm currently serving as the Acting Deputy Commissioner of the Division of Youth Wellness and Community Health. When not serving in this acting capacity, I serve as the Assistant Commissioner for the Bureau of School Health. Thank you so much for introducing this bill, and thank you for working with us on the amendments. The Health Department stands by, favorable with amendments agency report. We have a presentation to share with you today, and I just want to say I'm accompanied by a number of my colleagues who will present with me. To my immediate right is Heather Lynn, who is the Clinical Director of our School-Based Health Centers. Next to her is Melina Turtle, who is the Director of the Immunization Program. Right behind me is Kathy Smith, who's our legal counsel and who just happens to be a nurse, a benefit for us. And to the right of her is Renee Tucker, who's our School Health Services Coordinator. We have a presentation today. Would you like us to begin that? Certainly. So just for the sake of background, The Baltimore City Health Department's Bureau of School Health is responsible for providing school health services in most Baltimore City public schools. City schools provide some services in selected schools. Services are provided to nearly 76,000 students, and we have two models of service delivery that are used to provide these health services. We have school health suites, and these are located in every school. And then we have school-based health centers, and these are an enhancement of the services provided in school health suites. There are school-based health centers in 13 schools. 4 are operated by Baltimore City Health Department, 8 by Baltimore Medical System, and 1 by Johns Hopkins. So just to give you a little differentiation between the difference between school health services. So school health services, next slide. School health services are authorized to provide care for acute illness and injuries, emergency response that includes CPR and first aid, medication administration, health screenings, health education, including condom distribution and referrals in health education and skills training, reproductive health education, including condom distribution and referrals in middle and high school, case management, assistant with the review of childhood immunization records and referral for students who are out of compliance, assistance with communicable disease surveillance, health appraisals and referrals for medical follow-up, referrals for crisis intervention and counseling, nursing care plans for students with special needs, provision or coordination of advanced nursing care for children who are technology dependent, participation in the individualized education plan and 504 process for students with special needs. We participate in student support teams, and we provide student and parent advocacy. So in addition to the services that are provided in health suites, school-based health centers also provide primary care services, which includes annual health maintenance, early and periodic screening, diagnostic, and treatment, which is referred to as EPSDT services, sports and annual physicals, immunizations, care of acute illnesses and injuries, health education, rapid assessment for adolescent preventive services, referrals to mental health, basic laboratory tests, and reproductive health care, which we are subject to the minor consent law. Now, in order to receive the school-based health center services, students must be enrolled in that particular school and registered to receive the school-based health center services. And that requires parental and guardian agreement. So I want to talk a little bit about immunizations and services for city school students. In school health suites, staff contact parents of students who are out of compliance with vaccination requirements and at risk of exclusion from school. As needed, students are referred to providers for these vaccines, including the Baltimore City Health Department Immunization Clinic. In school-based health centers, we are authorized as vaccine for children sites, meaning that we receive vaccines at no cost, and as such, they can provide immunizations on site to students. And the VFC is a federal program that provides these vaccines. Let's just talk a little bit about the next slide, the immunization clinics. So the health department's immunization clinics offers vaccinations for uninsured, underinsured, or Medicaid eligible children up to the age of 18. The health department offers back-to-school immunization clinics based on staffing availability. We currently have 2 FTE nurses and run clinics 5 days a week. Vaccination rates for kindergarten students at Baltimore City Schools in the 2023 to 24 school year, with DTaP, it was 98.44%, polio, 99.66%, MMR, that's measles, mumps, rubella, 98.88%, hepatitis B, 98.97%, and varicella, 98.3%, making us some of the highest rates in the country. And this is based on information from the Maryland Department of Health Annual Report of Immunization Status. In our next slide, We talk a little bit about the family planning services offered in school health suites. Again, these are just our traditional health suites. We provide reproductive health education, condom distribution, and referrals. And the above services are also provided in middle and high schools and are subject to the minor consent law. Family planning services in school-based health centers. So in the 4 school-based health centers that are run by the health department, nurse practitioners provide pregnancy testing, family planning, counseling, and prescribe and dispense various methods of contraceptives. The health department also provides sexual health education and supports the students in select school-based health centers through our You Choose program, which is a health education program and teen pregnancy prevention program. The health department also provides sexually transmitted infection and HIV screening, treatment, and referrals. Students who test positive STIs are counseled, provided education, treated, and are given a follow-up appointment. Those who test positive for HIV and syphilis are given a warm handoff to the health department's STI clinic for follow-up services. Students are also referred to the health department's adolescent reproductive health program and STI clinics for additional services as needed. And now I want to talk a little about our family planning and reproductive health clinics. The health department has 2 family planning and reproductive health clinics at Druid and Eastern Clinics, and the following services are provided: contraceptives, including IUDs and subdermal implant, which is known as Nexplanon, emergency contraceptive, pregnancy testing and referrals, breast exams, pap tests, including for cervical cancer screening, STD clinic screening and treatment, HIV testing and counseling, substance use and mental health screenings and referral, individual, group, and family counseling, health education, and outreach. The health department also provides oral health services. We operate 2 dental clinics. The clinics provide basic and urgent dental care such as exams, x-rays, teeth cleanings, fillings, and extractions to eligible Baltimore City residents ages 6 and up. Specialty services requiring an oral surgeon are not available on site, but are referred out. The health department's Office of Oral Health Services also offers an EPSDT screening program, off-site preventive care, and community education for children 5 years and younger and their parents. In city schools students seeking dental services for emergency or hygiene care may schedule an appointment at either health department clinic. Parental and legal guardian written consent is required at initial and for subsequent treatment visits. Through an agreement with within city schools, through an agreement with the Oral Health Impact Project and Mobile Dentists, Smile Maryland, in-school dental exams and cleanings, dental x-rays, sealants, and preventive and restorative service can be provided to students whose parents provide written consent. For hearing and vision, the health department conducts annual state-mandated hearing and vision screenings to students in public and private schools in grades pre-K to K1 and 8. The agency conducts an average of 15,764 hearing and 17,729 vision screenings annually. If a student does not pass the screening, the health department notifies parents or guardians through a letter along with a referral letter to be taken to an audiology or eye care professional. Parents are asked to return the notice confirming that the child has received services, and we track and document these referrals. During the summer, we conduct follow-up calls, and that's because we have our hearing and vision testers are 10-month employees. During the summer, they do follow-up calls to parents that they've missed during the school year. And the parents, and they help the parents to receive the necessary care and ensure that support is provided to students. Baltimore City has the benefit of an expanded vision services for Baltimore City schools. So in addition to the state-mandated vision screenings that I just spoke about, We work with city schools, Johns Hopkins University, a nonprofit provider, Vision to Learn, and Warby Parker to implement the Vision for Baltimore program. Vision for Baltimore screenings, which are provided by the Health Department, are conducted on a rotating 3-year cycle. An average of 16,000 screenings are conducted in approximately 40 to 50 pre-K to grade 8 schools annually. Students who do not pass the screening get an eye exam in Vision to Learn's mobile vision clinic, with the consent of their parent or guardian. Students who need glasses can pick their style and the color of their frames. They get that choice. The glasses are then manufactured by Warby Parker and delivered to the student in school. So an average of 2,200 students receive glasses through the program annually. For mental health
I'm sorry,
services.
Ms. Francine, if you can let us know when next slide, because some of us are following from the presentation.
Oh, I'm so sorry.
No, it's okay, thank you.
I'm reading along on my paper, sorry. Okay, mental health services. Baltimore City Health Department is not the provider of mental health services in city schools. Behavioral Health System Baltimore, via a contract with city schools, offers mental health services at more than 100 city schools at all levels, elementary, middle, and high school. The Health Department's Office of Adolescent Health You Choose program funds BHSB to conduct mental health screenings for city students at 11 schools. Additionally, school-based health center providers administer the RAPS screening, which is an assessment tool to identify high-risk behaviors in adolescents, and that way they can identify students who have mental health needs. So as needed, screened students are referred to BHSB or other mental health service providers. Next slide. Actually, that was the final slide. So, thank you for the opportunity to present, and we can entertain questions at this time or.
Thank you so much, Ms. Francine. I want to go back to a few of the slides. And committee members, I just want to recognize that we were joined by Councilwoman Odette Ramos of the 14th District. And then Councilman Mark Parker from the 1st District. All right. Ms. Francine,
Yes.
if we can bring back up the presentation again. I want to go back to the first couple slides.
Yep.
Because I had some questions about the data points that you had mentioned.
Sure.
All right, go back up to the first one. All right. No, you're good. Thank you. Perfect. All right, if you go to the next one. All right, next one after that. So we are on. So immunization, I want to go to, and these slides don't have, okay, there we go, slide numbers. When we're talking about immunizations in school health suites, talk to me about how many kids each year. You mentioned like a 98, 99% rate for vaccinations, immunizations in schools. Is that after the fall? Talk to me about the data points like throughout the year, because one of the major issues that we're seeing is that that fall number is at 99%, but throughout the year, it's a little lagging. Talk to us about that data point.
So the health department does not maintain that data. That data is actually maintained through city schools, and in terms of the students out of compliance, that's something that's within the city schools.
And how many
data.
students are out of compliance on like a daily or weekly basis?
So that's not a number that I can have, and so my colleague over here, so she's can provide us.
Yep.
Okay. Hi. So actually, I was in preparation. I did get some numbers that are
I'm sorry, if you can identify yourself, please, for the record.
Yes.
If you can identify yourself.
Oh,
please,
sure.
for the
My
record.
name's Melina Turtle. I'm the director for the immunization program within the Baltimore City Health Department. Sorry about that. Thank you, Madam Chair. So I did get some numbers from our partners at Baltimore City Public Schools. So as of March 31st, the compliance rate is 98.9%, and that's based on the enrollment of 76,292 with 843 students out of compliance. 843.
Okay, and so those 843, what's the makeup of that, like, specific population? Are they newly coming to this country? Like, how are they falling out of compliance?
So I don't have it broken down, I just have the number, but I can say sort of anecdotally that those are probably children who are on a catch-up schedule, so they're either new to the country or new to the city, and maybe they're behind on 1 or 2 vaccines. And because the way the vaccines are given, there is minimum spacing between vaccines, so they may come in, get a group of shots, and then they get a return, if they come to the health department, they get a return letter saying, in 1 month, you can get these shots, or in 6 months. It depends on where they are in the schedule.
Okay, and how many of those children, do they come directly to the health department, or are they provided through like school health suites or school-based health centers within the schools?
I think it varies across all of that. I mean, some of them are coming to Baltimore City Health Department's immunization clinics. Some of them are probably, some of them are probably going to school-based health centers, and then some of them are going to their own providers, either an FQHC or a private provider.
Okay, that's I would like to have an official committee request, Trey. For that 843, I would like the breakdown of how many are going to school health suites, school-based health centers, or their providers.
I'm not sure how we can, I'll look into it. I'm not sure that we can identify where they go, because the school really is concerned about that they get the shots. They don't really ask where they go. I could let you know how many children we see at our clinic, but because we see a variety of students, we see a large majority of Baltimore City Public School students, but.
So the reason why I'm asking that question, and this kind of goes to the premise of this bill, is really maximizing the use of school-based health centers within our schools. And so we know that school-based health centers have been they've been around for a very long time now. And I've seen in other cities where school-based health centers are taking a much more proactive approach, documenting where children are going, how they're getting the care, and then also like the follow-up as relates to that specific care. And so as we're talking through today's bill, just have that in the back of your mind. Because it's more important for me to see how these 76,000 are using school-based health centers, and making sure that if we're providing funding for school-based health, and we provide a lot of funding for school-based health centers in the city, I want to make sure that it's maximally allocated and used. My next question has to deal with what percentage of students utilize school-based health centers or school health suite services in the city?
So, school health suites are in every school. They're available to every child.
Yep.
And so they are used based on the needs of the students, whether they come for well-child visits.
Are we tracking that?
We track the number of
Okay.
students that come to school, that participate in school health suites. We also look at the numbers of students who participate in school-based health centers, understanding that school-based health centers are in 13 schools.
Sure.
Only in 13 schools. So we find that about somewhere around 50% overall of the students enrolled in the individual schools actually come to the school-based health center. It varies according to the school and according to the grades. We find that students in the elementary grades are more connected to their primary care providers, because bear in mind that school-based health center is not the student's medical home. We're just an adjunct to the child's primary care provider, and we actually prefer that the student get their care from their primary care provider. and so that that primary care provider can track all of the care that they receive, including any specialty care. So, and during the day when the student's in school, they can certainly take advantage of the school-based health centers, bearing in mind that school-based health centers are not open on the weekends. We're not open when schools close. We're not open during the summer. So we want to make sure that the students have a primary care provider that actually follows them.
But Ms.
So
Francine,
yes.
what is that number? So I'm looking for two numbers.
Okay.
The percentage of those students, you mentioned 50%?
About 50% of the enrolled students
Of the enrolled
in
students.
school-based health centers take advantage of the who are actually enrolled in a school-based health
Are we
center.
tracking that by school? So,
We do track that by school.
okay. And so do you have that information for today?
I don't have it today, but I certainly can provide it
Okay,
to
that's
you.
an official committee request as well. I'd like to know by school how many are attending, how many are participating in the school-based health centers and/or school-based health suites. I'll save my questions for the next round. Councilman Conway, did you have a question? Okay. Anybody else have any questions? Yep, Odette.
Thank you, Madam Chair, and my apologies for being late. Good morning, everybody.
Good morning.
Thanks for all you do. I had a question about when a student needs something from the health suite. What's the communication with the parents? Is there a limit to, like, elementary school, you definitely communicate with the parents, but maybe at middle school you don't? Does it depend on what they're in for? Obviously, some of the preventive work that you're doing, you notify the parents that that's available, and the parent can say to the child, yes, can you go to do the screening, but if a child is not feeling well or whatever. I will admit, I have a child in public school. I do get the call, so I'm glad that that does occur. But I was just curious if there was a level of communication depending on what it is that the child is taking advantage of.
Sure, we consider parents to be very valuable partners, and we certainly don't want to provide any care to a student without, the parent's knowledge. So for a health suite, whenever a child comes for a visit, there's a health suite visit report that's sent home to the parent that tells the parent exactly what has happened and what follow-up care the child needs. In a school-based health center, again, we do the same thing. There are certain services that can be provided under the minor consent law where, parents do not have to be. We try to make parents those partners. We encourage every student to make sure that they're, to discuss it with their parents, the types of services that they receive, because we feel that a parent can be a valuable partner in ensuring that the student gets the care they need. But under the minor consent law, again, there are certain services that a student can receive without parental consent.
Okay, yeah, so I just wanted to make sure that was, because there are some things that may not want to be discussed with the parent right away. So, I'd be interested, I'll look into the minor consent law a little bit more, but I was just interested in that interaction. So, thank you, Madam Chair.
All right. Yep.
I appreciate you asking that question, Councilwoman. I literally just had a conversation with a constituent last night about exactly that issue. So it's important timing. In this constituent's particular instance, they have a 12-year-old, and they were not allowed access to information regarding their health care unless that 12-year-old said that their parents could. Is that how it works, more or less?
And I have my colleague here, Heather, who's the clinical director of school-based health centers, who can, give us a little bit more information about the minor consent. You press that button. Yeah, got it.
Okay. Hi, I'm Heather Lane. I'm the clinical director for the school-based health clinics that are run by the Baltimore City Health Department. So to elaborate a little bit on that, so the minor consent law states that a child can come to a clinic for services without their parental consent as long as it involves family planning, services. So in those cases, we do not contact the parents because we have to follow that law. So they can see us for anything family planning, counseling, contraceptives, sexual transmitted infection screening, and results without a parental consent. Otherwise, I'm sorry?
Mental health.
And mental health, yes. Without a parental consent, we do provide referrals for that within the school. If they do see us, because other than the minor consent law, we do require registration and consent from the parent for them to access the school-based health centers. So once we have that on file, and we know we have the consent of the parent, if they come in for any other services that the parent has consented for, then we do contact the parents while the student is present, and we also send home a note regarding the visit and what our recommendations are.
I see. So in a scenario where a young person has a fever, a parent may be notified.
Yes.
In an instance where a young person is getting a mental health diagnosis or something like that, and they may not necessarily want to share the conversations they're having with the mental health professional, they don't have to share that with their parents.
Correct.
Got it. Thank you.
Unless, of course, there's, some risk of harm to the student, then, of course, we would have to, break
Well, that would go well
confidence.
past the parents then.
Correct.
Yeah.
Right.
I appreciate it. Thank you for clarifying.
You're welcome, thanks.
Any other questions, colleagues, before I go forward? All right, I have a few other questions. I want to go back to that engagement rate that you mentioned, Ms. Francine. Talk to me about your workflow or community engagement strategy to get more young people integrated within school-based health centers or school health suites. You mentioned that 50% rate. That's a little low.
So what we found actually in some of the studies actually is around about 60% of school-based health centers,
So it's
sort of
59
nationwide. So
59% as opposed to 50%.
About nationwide, around 59 to 60. And the reason is Hopkins has actually completed an evaluation that indicates that the students that are enrolled in school-based health centers are the ones that have the greatest baseline health, education, and social risk. So they have more risk than the individuals who are not enrolled. So we find that the school-based health center is seeing the students that have the greatest need, because many of those other students have another source of care, and they're usually seeing their PCP, so they're not the primary care provider. So they're not coming to the school-based health or not enrolled because the parents may not necessarily feel that there's a need because they're connected and they're seeing a primary care provider. So for those students who are uninsured, who use the school-based health center safety net, we feel that we're reaching that population. But certainly we want to enroll as many students as possible. So so at the beginning of the school year, and my colleague Heather can enhance my response when I'm done, we do participate in 9th grade orientations or any orientation that the school has. We try to send the information with school registration, so we catch kids when they register for school. We participate in parent-teacher meetings, any outreach activities that they have in the schools. We've developed flyers and brochures and things that we submit to parents. So we encourage students to participate in that school. So we have many touch points during the year to encourage parents to enroll.
And is this paper or electronic forms?
So mostly paper. So
Okay. Have you all thought about taking this electronic?
we've thought about it.
I'm sorry?
We've thought about it, haven't done it, but that's another thing that, we certainly can do. We have the information, on the health department's website, letting people know about that, but we certainly can do a bit more with that type of information.
And Heather, would you like to add to that before I provide a follow-up question? I'm sorry? Would you like to add to that before I provide a follow-up question?
No,
Okay, so with the electronic pathway, how long have you all been thinking about taking these forms electronic? So one of the major issues that I'm having, and I visited a few school-based health centers, and there was a lot of paper. There was a lot of paper, and it wasn't really connected to, like, I know you all go through your electronic health records, but I found disparities from where that paperwork is actually connecting to the EHR system that school-based health nurses, school nurses are using. How have you all kind of reconciled that? Because I feel like we're missing a large portion of the population. If we can send a link, send a text message, there are health providers and insurers that actually do that text message model. I'm wondering if we can utilize that within the health department.
That's certainly something that we can explore. It's not something that we have done, but it's something we certainly can explore.
Okay. Do you think that you'll be able to have some sort of brainstorming session within like the next 3 months, 6 months? Because what I'm doing is I'm making sure, like, as we're having this conversation now, we want to make sure that we have an opportunity to prepare for the next school year. And I would love to have something like this implemented by the next school year.
So the health department as a whole is implementing a department-wide electronic record system, Ocean Epic, which the school-based health centers have not joined us yet, but certainly will be joining in the next several months. So we think that we can provide you some, an update on where we are in integrating the school-based health centers into that Ocean Epic.
And we say the next several months, what does that look like? Is that 3 months, 4 months?
So I'm thinking, and I know we're planning on the beginning of the school year, which is August.
Okay.
In bringing the school-based health centers into the health department's Ocean Epic system. So, we should be able to provide some type of report, I think, within a few months after that, after we've done the integration.
Great, that's an official committee request, please. If we can get a status update from the health department related to their community engagement plan of integrating school-based health centers within their, you said the OSHA Epic?
Ocean Epic.
Yep, within their Epic. All right, perfect. Colleagues, before I ask any more questions, do you all have any questions? Yes, James? I'm sorry, Councilman Torrance.
No worries. Thank you, Madam Chair. This question is for finance in the law department. I understand we don't have plenary power over the school district, but we do have the powers of the contracts clause. My understanding is that our agreement with city schools is that we give them somewhere up to $16 million a year for self-help services. Could we, through a MOU, through our contract clause, upon the renewal of our agreement with them, since we were forced by the General Assembly to give them the money anyway, to discuss what services that they should or should not offer?
Probably not, because it's pretty much governed by state law. So state law says that all local school systems must work with their local health department and must meet certain criteria. So it's really a matter of preemption by state law. We couldn't require them by contract to violate that state law or to provide services that they're not, able to provide already. I mean, pretty much state law covers everything we've talked about here. I mean, if they could cover more with more money, there's nothing that prevents them from being more responsive. It's just a question of, do they have the resources or ability to do that? But also, part of that is, all of these kids and their families have the ability to refuse the treatment or to go somewhere else.
Yes.
So,
If I
Yeah.
remember my experience at City Schools, we only pay for the nursing positions to be.
there's an MOU between the city and the schools with respect to health suites and health services, but there's also the omnibus MOU that comes, basically that exists between the two entities since the school system was separated in 1997. And the basic premise there is the city must provide every service that it always provided for them unless the two agree otherwise. So it's a sort of a complicated long-term relationship there that has, sort of an omnibus agreement between the two of them. But ultimately, you're right. The money comes from the same pot anyway. So
if I were to put in legislation to review our current agreement requiring both our portion to start negotiating a new agreement, or if I requested state action to provide us opportunity to look at a new agreement, would that be justifiable?
I mean, sort of, except that already exists. The state law already requires the two parties to come to an agreement, and your local law wouldn't affect the existing
So-
agreement or when it's renewed or renegotiated.
So if my requirement, so case in point, if I were to pass a statute that required that the health department and the city of Baltimore move forward with seeking state action to get additional, so case in point, if I wanted to go to our state delegation and I wanted to amend the statute and requested that they have specific changes to the statute, would it be lawful for me to kind of push both parties to the table to discuss that?
Well, you could certainly push to change state law.
And Councilman, last question.
So my committee request would be, one is a meeting with the administration, the health department, and the city schools to discuss the potential of moving forward in the 2026 General Assembly with a new agreement of how we will approach school-based health in the city of Baltimore. I think that is a fair thing to leave this meeting with. Reason why is because while we have state preemption, I firmly believe that our contracts clause could allow us to move in a different direction. But because you are giving me counsel, I think we should have a conversation with both parties about how we proactively go to the General Assembly and seek a better agreement so that we can serve our citizens better.
That's an official committee request?
Yes, ma'am.
All right, thank you. And as a follow-up, Hillary, when was the last time that the MOU was signed?
I have no idea. It's
Is it
periodic.
within like 1 year, 2 years?
I have
3 years?
no idea. I've
Okay.
seen agreements, obviously, I saw one from late 97 into 98
Sure.
originally, and then subsequent agreements after that, but there are separate agreements on different aspects of the relationship. So the Health Suite, Health Center agreement is separate, but again, it's kind of, state law already mandates what the parties do, so the agreement is more about like funding than it is about, providing something that we're already required, all local health departments are already required to work with their local school system to meet the state requirements that the state sets forth. Like the state has a entire commission dedicated to school health centers across the state, and they mandate what is in a school health center. So like our agreement isn't really, it's our agreement with the school system because we're two separate legal entities, but both entities are following the mandates from the state law.
Yeah, through my research, we're looking at about a 3-year lag with this agreement. Ms. Francine, did you want to say something?
Yes, I think I defer to our legal counsel. Kathy, I think. Oh, you can.
Good morning. So currently, any day now, there will be signatures placed on a new agreement, a renewal of an agreement between the school system and the city. And that specifically relates to the breakdown between what the city will pay and what the schools will pay and what services we will provide and what services the schools will be responsible for. As Hillary stated, the actual definition of services is set forth in state law.
Yes.
And that agreement anticipates that we'll provide all of those required services according to the breakdown that's set forth in that agreement, and it should be signed any day.
But I don't think, and Councilman Torres, correct me if I'm wrong, I don't think that you're looking at the types of services. You're looking specifically from a funding perspective, so this MOU would be very important. How long has it been in that status of any day now?
The status of any day now has been in the last, I would say in the last week, but.
In the last
it's
week,
been
okay.
In the last week, but the agreement has been under negotiation for years.
For years,
For
okay.
years, yeah.
Director
So-
Themelis, can we get a status update on that agreement, please? I'm sorry? Go ahead, Director, excuse me.
I was going to say, I will work to get that.
Thank you.
I just want to clarify. So the reason why I'm asking this question is because there is, and I
I serve West Baltimore. I am in a healthcare desert. If we have an opportunity to figure out a funding model or work with our partners at the state level to address what I need for my Black and brown children in West Baltimore and families, I think that is something that we should go to the General Assembly about. As someone who's worked for both entities, I see the disconnect in terms of what we're required by law to do and then what we're required to fund. I just want to make sure that we go to the table, we have an agreement in place as partners to say to General Assembly, we have different health disparities in most of the state. We need a different funding model that allows us to address it because people are dying, right? I can tell you that many of us have allergies. I went outside last week and I literally could not see because of the amount of pollen, right? But I recognize that I live in an area with mostly trees. Some of my neighbors have none. So they don't have that clean air on top of the pollen, right? So I think that we need to address this from a different perspective. I think after someone who's helped with immunizations at city schools, who understands the nursing contract and had to track which agency had certain nurses, I think that we need to not do hodgepodge where it's just one system for a health department, then another health system, then city schools, and then we now have complicated this, we're bringing in Hopkins and Morgan, right? I think we need to have a one clear pathway approach and that it's clearly defined, because when I count, there's like 6 different people who are now providing health services in our suites, and the level of care is always going to be different.
And
There's not-
Councilman, I think that's the integrative approach of bringing it into the electronic health records. And so I think that's where kind of we need to have more clarity about what that plan looks like, because you are right, we have many entities that are funneling information. The data may not be consistent, or the data may not be even tracked at all. And so I totally agree with you. So would you like me to add you to that, my official committee request? All right, perfect. Councilman Parker?
Yes, thank you, Madam Chair. And thank you, Health Department, for being present with us today. Remind me, I'm sure it was on a slide earlier, but with the 4 centers right now, school-based centers, what are their locations?
The 4 that are operated by the Health Department are at Digital Harbor, Reach, Augusta Falls Savage, and City Springs.
Yes, very good. Oh, City Springs.
Yes.
That's great. I'm sure it'll be great. They're in the new building, there are plans to integrate that into their new space?
Yes.
That's perfect. That's a great resource. How's that model been, just in general, how's that model been working so far? What kind of feedback do you all receive regularly from practitioners, school families, school staff about current offerings? What's that kind of communication, iteration loop look like?
I'm not sure I understand your question.
Sure.
If you
What
can
kind of
clarify.
what's your assessment of how that current model of those four centers, how it operates, and what kind of feedback do you all receive from students, from school staff, from parents about the kind of services and how it operates? So what does that look like?
So we, currently we're not fully staffed in those 4 school-based health centers. We are in the process of hiring nurse practitioners. During, the pandemic and pre and post-pandemic, we lost a number of our providers. So we're hiring so that, we can actually begin to provide additional services. We get feedback from our providers in the sense that they're happy to have someone available for their students during the day, and our nurse practitioners communicate directly with the PCP. When a student has a visit, they provide that feedback to the primary care providers. And I believe that by having that coordination of care, I think that we're satisfied with the care that's being provided in our school-based health centers.
How long have we operated at that level of 4 centers? Has that been a long-standing practice? Was there a time we did more? Is there a hope to do more, recognizing budget realities?
So the school-based health centers have been operating in Baltimore City Schools since 1985. And there have been ebbs and flows. There have been various different partners. The health department has provided services. We partner with Baltimore Medical System. We've partnered with various federally qualified health centers throughout the years. The numbers have increased, they've decreased as schools have closed. So there are currently 13, although the health department only provides services in 4, there are actually 13, 8 operated by Baltimore Medical System and 1 by Hopkins. So the model has been around for, quite some time.
I appreciate it. And the final thing, I just wanted to commend you all. I know that the chairperson and I had a conversation around this part of the bill, and so I appreciate it. And then number 3, offered by the health department, that, and we've had some conversation here around kind of the role of parent and guardians, how information flows, and so just wanted to note that amendment, to appreciate it, and to appreciate the conversation we've had about it here. Thank you, Madam Chair.
Of course, Councilman. Ms. Francine and Health Department, I wanted to transition to the operations of these school-based health centers. You mentioned that you're still in the hiring of nurse practitioners or MD that is present. Talk to me about how many FTEs that you are waiting for, and talk to me about some of the engagement strategies that you're doing to kind of make sure that we can hire appropriately and most efficiently.
Certainly. So I think we just, and Heather can tell me, I think we just hired
And I'm sorry, also, what's the vacancy rate that you are looking at?
So currently we have 2 nurse practitioners on board. A third is scheduled to come on the 24th of this month, then we'll have 1 vacancy. And so Heather, who's also a nurse practitioner, has been providing services 2 days a week in order to ensure that students are seen. So one of the things that, as you know, nurse practitioners are in that category of nursing professionals where there has been, a traditional and long-standing shortage. So we have, the city increased the nursing salaries sometime in the last couple of fiscal years, and so we have been able to attract more candidates. We've also engaged a digital marketing company that has used videos, including some of our current staff, and those have been on social media, and so that they've brought us several new candidates that have been directed to our website. So we anticipate being fully staffed, I'm hoping by the beginning of the school year.
Great. If you can provide an exact number within fiscal year 25, yeah, that's for 25. Yeah, fiscal year 25. How many school nurses have you brought online since in this year?
Are we talking about school nurses?
Yep, school nurses.
School
Yep.
nurses, not nurse practitioners, school
Okay,
nurses.
thank you. And that's an official committee request. Thank you.
Okay.
All right, next I want to talk about utilization of services. So one of the major issues that I was hearing from some of the parent groups and parents is that school-based health center engagement is not consistent, meaning that the school-based health center and/or school health suite is not really consistently open. You mentioned like 2 days a week that you're going to schools. How are you all balancing making sure that these school health suites are fully staffed, even within the vacancy, and also your school-based health centers are fully staffed?
So school health suites are open and available every single day. So there's someone in a school health suite. So the school health suites
But is that someone a school nurse?
This is either a school nurse or school health aide. A school health aide can provide nursing services under delegation by a school nurse. So that person can provide most of the services that a child needs during the day in a health suite. So there's someone there every day in order.
So just that I'm clear and committee members are clear, our school health suites are fully staffed. Is that a proper assessment?
So there's someone available in a school health suite every day. There's not necessarily a registered nurse, but it is a certified nursing assistant who's also a certified medication technician. So that person can provide the basic needs of a student during the school day by delegation.
Does that align with the COMAR regulation?
Yes, it is. In terms of, now it's in line with the ability to have someone present. Is it in line with our best standard of care, which would be a full-time nurse in every school? We're working towards that, but in the you know, since we are not able to achieve that currently, we do have the school health aide who can provide the basic needs of a student during the day.
Kathleen, can you answer this question real quick? And I mentioned the actual regulation. So does it say a school health nurse, or does it say like a school health aide that has to be available at these health suites during the day? So I'm trying to make that distinction.
School health suites we're talking about.
Yes, that is correct.
Okay, school health suites, under the Kerwin legislation, there is, oh, I pushed it. Can you hear me now?
Oh, yes, we can.
Okay.
And if you can identify yourself again.
Sorry about that. So under the Kerwin legislation, there's a requirement that there be an RN in every health suite. That has been an impossibility.
Okay.
Just because of resources.
Yeah.
So the model that the health department uses for the provision of services to the schools is a model where we have one or two, we have nurses who are supervisors who cover, and I might get this, Francine, correct me if I'm wrong, 2 to 3 schools each. And so that's the nursing supervisor role, and she or he are responsible for a group of schools. Then within those school health suites, we'll have medical assistants who are able to provide a certain level of service.
Yes.
They're also allowed to provide a slightly higher level of service for some students if the registered nurse is comfortable with delegating that task to that individual.
And thank you for that clarification. One of the ways that I'm going to kind of press us within the health department is forming additional partnerships. We have 4 major public health institutions here in the city of Baltimore. We have various schools of nursing. Have you all engaged with those schools at all?
So in terms of engagement, we provide, the health department serves as a clinical rotation site for the nursing schools in the area, meaning that nursing students, for the community health portion of their training, they do participate and come to our school health suites for that clinical rotation. In terms of partnering Baltimore City Schools, and one of our colleagues is here, can also speak to that, has engaged and partnered with some of the schools of nursing to provide coverage in health suites.
I would love to explore that with you all, because I think that, you know, one of the things, our pre-briefing session, you all shared how capacity was an obvious issue. I know, Melinda, you've done your woman's job in this role to date, but I want to make sure that we're not only providing you all with the capacity and funding, we're also providing you all with the influence as well. So I would love to explore what that type of partnership, for example, University of Maryland, having some of their school nurses actively engaged with you all, kind of providing that care that you would need, some of the graduate level students, having, you know, those types of preceptor and or fellowship programs within the health departments, because it's one of 2 reasons that I'm saying that. One, it's making sure that our nurses that are working within Baltimore, they have some sort of connection to Baltimore, they understand Baltimore, and number 2, that we are maximizing student teaching within these great institutions within our city. And so I know we have, you know, University of Maryland here today. I would love to see what that type of partnership would look like, specifically bringing those student nurses, those graduate level student nurses, formally within their institution into our school-based health centers. Is that cool?
Certainly, we can explore that.
Okay,
Yes.
thank you so much. All right, colleagues, did you all have any other questions? Yes.
Thank you. I just wanted to clarify, just for, again, this is a fairly new topic for me. So the health department hires the nurses and manages the care in the health suites and the 4 health centers. Is that correct?
Yes.
So the agreement between city schools and the health department is basically that the health department has a staffing level mandate and all that by the state, but that's in the agreement, right? So we the city don't just hand a bunch of money to the school system. We're actually managing the the nurses and all of the healthcare providers, is that correct?
So we manage, and Kathy can weigh in where she feels appropriate. So we directly manage the staff that are in 100, I think it's 114 schools, and the school-based health centers. The school system manages the care in the other 36 schools.
Oh, so it's different, but depending on the school and the relationship then? Okay. I think that'll be helpful for us to look at the agreement once it's signed so that we get a better understanding of that relationship. Because if that's the case where we pay the school system to manage the 36, I think you said 36. Yes. And the city health department manages and hires the staff for the 120 to 60.
140.
Right, 140. And then there's the 8 that are partners that do those. That sounds like it's going to be difficult in terms of levels of care and consistency like Madam Chair is trying to get to.
So it is the expectation that the level of care provided in all 149 school health suites would operate the same. We have the same school health manual. We have the same requirements. You know, the COMAR is expected to be followed across all of the school health suites.
So then the data management that you just talked about with, that the health department is doing for those, for your entire agency as well as integrating the school. So the 36 that the school's system then manages would also utilize that same system or not?
For the school health suites, which is a different, which is the traditional services, that electronic health record would reside with city schools, and then everyone would enter the data into the health suite electronic system. For the school-based health centers, which is, again, like the primary care, that's a different medical record, because
Right.
one is governed by FERPA, which is an educational record, the other
Right.
by HIPAA, which is the health record. So those two don't integrate. So in a school that has a school-based health center, you actually would have two separate systems operating depending on which service the student is accessing.
Okay, well, I think it's going to be interesting to see, based on your committee request, how that works out. And I would like to see, I don't know if we formally requested a copy of the agreement, but once it's signed. Yeah, okay, great. Okay, thank you. Thank you, Madam Chair.
Thank you. Any other questions before I ask my last question? All right. This is my last question, Ms. Francine. On the hearing and vision services for city schools, one of the data points that you mentioned was 15,764. Is that out of the 76,000?
So the vision screenings are provided from pre-K to the end of the 8th grade. Those are the mandated. So those screenings would involve the students in the pre-K to 8.
Okay. So to my just to my back of the envelope math, that's like 10% of the overall student population.
So the way that it could be, the way, it depends how you interpret that. But we provide all of the screenings in all the schools that are mandated. So those we do. Then on top of those, with the Vision for Baltimore, we provide screening in non-mandated grades as well. So that we do have, we exceed the state requirement for hearing and vision screenings in Baltimore City Public Schools.
So I'm trying to get at a utilization rate. So if we have the 76,000 that you mentioned as total student population, and the data point here that was shared is 15,764 for hearing, and then 17,729 for vision. What I'm trying to ascertain is whether that number is a subset of the total number. So from the back of the envelope, that's about 10 to 12% of city school students that are getting those particular screenings, whether it be hearing or vision.
Yeah, yes, I mean, a student can get a hearing and a vision screen. So most of them are getting a hearing and vision screen.
Okay.
And then some students will get the enhanced vision screen through Vision for Baltimore. So that, yes, so there's, not the entire population is getting a screening during the year. We screen in the grades where we see the most problems with visual acuity, which is the mandated grades. And then with Vision for Baltimore, we add additional grades on a 3-year rolling basis so that students who might not get a screening between, 5th and 8th grade, they'll have the opportunity to get a screening through the Vision for Baltimore program.
And there are two reasons why I bring that up. One, because I noticed that the grades, thank you for mentioning that, they only receive it at certain time points. Grades 1st through 8th grade, that's a long time.
Absolutely.
For us to have some sort of, so you mentioned that it was every 3rd year rolling basis?
Yes, so,
Okay.
and the reason, again, the reason, between, the early grades, we certainly want to catch the children when they first enter school. And then around about the 8th grade is again where, kids going through puberty, and that's where all the changes occur with the eyes. And that's the reason why that, particular grade was chosen by the state. And the purpose of for Vision for Baltimore is to help to intervene in those earlier grades between the 1st and the 8th grade.
Okay. My last question is, do you all have any written protocols as it relates to any ad hoc vision or any type of health outcome? How do you all determine whether a child needs follow-up services? Do you all have any written protocols that can be shared with the council?
So for after screening,
yep,
so yes, there are,
Okay.
guidelines for,
No, but
when a child is.
I mean specifically within the health department.
For when a child is referred, so what the cutoff, yeah, we have things like that, yes,
Okay.
absolutely.
That's a formal committee request. If I can get those guidelines and specific protocols from the Baltimore City Health Department related to any follow-up and or referral for care for abnormal screening. All right, last question, Councilman. You'll round us out.
Oh, yeah, I'm sorry. I'll wrap us up. I just want to say I appreciate the Vision for Baltimore. As someone who's had a nephew who was identified by it, and recognizing that it is important to academic work that we have at city schools, I would like for just the council to have a copy of their most recent report from it, because it shows, I believe it's 4 years out from last time that we had a report. It showed the academic achievement of those students who did take advantage of the services. I think it's an opportunity for us, and this goes back to going above and beyond what the state says we should do. I think that if we're able to do that for just that purpose, we could do it for other purposes as well, because one of the things that I saw is that we're not even screening for diabetes, and there are a number of kids in our schools who are type 1 diabetic who don't get identified until high school, when they actually do sports. So I think that this is where, great, we did things for vision. Let's try to get kids tested for diabetes, as we know a lot of them live in food deserts,
Yep.
and figure out how we create a continuum of care outside of it. So that was the goal of what my earlier comments were about.
Thank you so much, Councilman. And just for everyone's knowledge and the public's knowledge, we're going to be having a follow-up hearing related to this particular bill, specifically geared toward that precedent that you're talking about, making sure that we're not just doing the status quo, but that we are really identifying, we're leveraging our hospital institution partners, our academic partners, so that we are identifying and screening for these chronic diseases in our young people very early, so that they can get on a trajectory for greater health for life. All right. We will now hear from agencies, we will now hear from representatives from our city agencies, and then have an that's it, sorry. We will now hear from our city agencies. First, we'll start off with the city solicitor.
Thank you, Madam Chair. The Law Department has reviewed the amendments and approves them for form and legal sufficiency, so the bill, as well as amended, would be approved for form and legal sufficiency.
Thank you. We have the Baltimore City Health Department. You all provided some amendments. Did you want to go over them?
Oh. I'm certain I don't. I actually don't have those amendments.
No
I think the
worries.
report was submitted.
Yeah, so a copy of the amendments were submitted to colleagues. If you have any questions, we can follow up later. Baltimore City Public Schools.
Good afternoon, Melissa Broom, City Schools. We have submitted our agency report and stand by it. We have no concerns with the legislation as amended.
As amended,
Thank
yes.
you.
Thank you. And finally, the Department of Finance.
Good morning, everyone. Gabriel Stewart Zykowitz from the Department of Finance. We've reviewed the amendments and we do not oppose the legislation as it will be amended.
Thank you so much. We'll now receive public testimony. Those in attendance, once you come to the dais, if you can just identify yourself for the record, and then committee will be able to hear your testimony. I first want to bring up David Castro.
Yes, hello, thank you, Madam Chair and committee. I am David Castro, the Community School Director at Lakeland Elementary Middle School in District 10. I just want to say that the longer that I work in education, the more it becomes apparent to me that what I once saw as a very typical childhood was actually pretty privileged. Despite the fact that I'm a second-generation immigrant whose first language was not English, I had a stay-at-home mom who was able to tend to my needs. Anytime I needed to be picked up late or there was an emergency closure, she was there and available. And we had health insurance. So whenever I was sick or needed to go to the doctor, we just went. And the reason why I didn't view this as privilege is because I thought it was the way it was supposed to be. Now, let me tell you what I see at this moment working as an educator. I see single parents who are struggling to keep their head above water, just living in apartments with mold and communities with lower air quality while their children are developing asthma at higher and higher rates. I see families without health insurance that are struggling to decide whether to send their kids to a doctor simply because of not being able to afford the cost, an out-of-pocket expense. I see families who struggle to afford lice treatment that they're supposed to apply weekly, but they just, without having to separate families with having infections and then sanitize all the living quarters, the toys, the clothing, they just give in to home remedies that don't end up being as effective. And I see a rise in dual income families that are still being outpaced by the cost of daycare. So I see families who are new to this country as well that are completely overwhelmed by the amount of information that they have to absorb, and now having to be told to get vaccines that they haven't had to get previously, not knowing where to really get them, and struggling to comply with school requirements, which all of this leads to children who stay sick longer, who are more chronically absent, and who generally fail to get treatments for long-term ailments that we could otherwise see them as generally preventable. So I throw my support behind this bill because addressing disparities between child health care is exactly the kind of thing that can bring people together in a time where we seem to agree on very, very little. Now, Lakeland is fortunate to have built the partnerships and have the resources as a Title I school and a community school to be able to address and bridge some of these gaps, like the mobile dental clinic that comes to the school every year. Now, that's free of charge. There is a permission slip and consent that families have to buy into for that. Not every school is so fortunate, but for a significant number of our students who take advantage of this service alone, that is their first dental visit ever. And we are a combined elementary middle school from grades pre-K all the way to 8th grade. Now, the fact that we could really have this kind of preventative care through the same hub to which families are already entrusting their children for over 180 days of the school year is the most logical answer to an illogical problem. That's the way I see it. I may not understand why salaries have failed to rise to the proportionate levels of cost of living, nor why pay discrepancies still exist among the same tried and true classifications of gender and race, but expanding these health services at schools only helps to level the playing field. And it's hard to argue how an American citizen classified as either an independent contractor or self-employed can actually see themselves facing the same dilemmas as those who are homeless, jobless, or just here as an undocumented immigrant. Now, access is opportunity, and by providing more access to health suites and health services at schools helps families facing those similar dilemmas. So nothing would make me happier than to see their children, who are all too used to the struggle of modern everyday life, have an opportunity to live the same typical and uneventful childhood that I had. Thank you.
Thank you. Thank you very much, David. Do we have anyone else that would like to testify?
Good morning, Madam Chair, Vice Chair Conway, and members of this committee. Truly, my name is Samuel Barris, Director of External Affairs with University of Maryland Medical System. I'm joined by my colleagues today that will come and share a little bit about our services, in which our partnership with Baltimore City Public Schools and the work they are doing to build lasting relationships with the community we serve.
Thank you, Sam. Good morning, Chair Porter, Vice Chair Conway, members of the Public Health and Environment Committee. Thank you for the opportunity to testify. I am Rhonda Boozer-Yeri, and I proudly serve as the Community Engagement Manager for the University of Maryland Medical Center. UMMC operates across 2 campuses, both downtown and midtown, and is deeply committed to delivering high-quality, patient-centered care that reflects the diverse needs of Baltimore's communities. As a trusted healthcare institution rooted in the heart of the city, we believe that equitable access to health and wellness begins long before our patients walk through our doors. As one of the largest anchor institutions in West Baltimore, we work in partnership with our community to build and support a healthier, more empowered, and socially cohesive city. Our ambition is to dramatically improve health outcomes, increase life expectancy, and reduce hardship. At UMMC, community engagement is not just an initiative. It is a core part of our mission to advance health equity and improve the quality of life for Baltimore residents. We forge intentional partnerships that go beyond clinical care to address the social determinants of health, education, employment, education, and opportunity. Our goal is not only to treat illness, but to help ensure the social, emotional, and physical well-being of every child in Baltimore. As part of our partnership with Baltimore City Public Schools, we are currently working with 10 schools in West Baltimore to ensure that students, families, and school staff have access to essential resources and services. These partnerships connect school communities to health screenings, mental health support, immunizations, nutrition education, and other vital services that contribute to healthier learning environments. One of our flagship collaborations is the Edmondson Westside High School, where we developed a unique surgical technician training program. In partnership with the school and its students, we built a fully functional simulation operating room on the campus that is right there at the school, providing hands-on training that prepares students for surgical technician certification and immediate employment in the healthcare field after graduation. Additionally, through our corporate partnerships with Cristo Rey Jesuit High School and YouthWorks program, we offer Baltimore City youth paid work-based learning experiences at UMMC. These programs provide students with exposure to healthcare careers, mentorship, and skill-building opportunities that prepare them for success in higher education or the workforce. We also understand the critical importance of access to fresh food and healthy nutrition, especially for students and families living in food deserts. That's why we partner with schools to address food insecurity and promote healthy eating habits, including organizing trips to local farmers markets and food distribution events. At UMMC, we remain steadfast in our commitment to working alongside our partners, including Baltimore City Public Schools, local organizations, and community leaders to build a healthier, safer, and more equitable Baltimore. Thank you again for the opportunity to testify today. I look forward to continuing our shared efforts to address Baltimore's most pressing health challenges and to reduce disparities in child health by expanding access to comprehensive health services for children across the city.
Thank you.
Thank you.
Thank you.
Good morning. Good morning, Chair Porter, Vice Chair Conway, and members of the Public Health and Environment Committee. Thank you for the opportunity to testify today. My name is Jasmine Pope, and I serve as the Director of Programs and Strategic Partnerships in the Division of Community Pediatrics and Adolescent Medicine at the University of Maryland School of Medicine. At the University of Maryland School of Medicine, we believe that advancing child health equity must begin in the places where children live, learn, and grow. School-based health programs are a critical tool in delivering care directly to children and families, especially in communities that have been historically given barriers to access. The School of Medicine is honored to play a vital role in advancing health equity in Baltimore by training the next generation of physicians and scientists, conducting life-saving research, and supporting innovative community health-based programs. One such program is TEAMS. Teaching, empowering, advocating for medical and social equity, a community-based healthcare initiative out of the University of Maryland Children's Hospital. TEAMS is dedicated to improving the physical, social, and emotional well-being of children and families in West Baltimore. Through a trusted, neighborhood-focused health model, TEAMS delivers accessible, high-quality pediatric care while addressing chronic health disparities in historically underserved communities. The TEAMS initiative fosters cross-disciplinary collaboration between the University of Maryland Children's Hospital, community partners, by integrating pediatric care, preventative services, and community health navigation beyond traditional hospital settings. This approach strengthens partnerships with Baltimore City Public Schools, faith-based organizations, and local nonprofits, ensuring accessible, comprehensive health care for children in underserved communities. By partnering with local organizations, schools, and faith-based institutions, TEAMS reduces barriers to healthcare access by meeting families where they are and tailoring services to reflect the needs and strengths of each community. The health challenges that we face in West Baltimore are urgent. In Baltimore City, 1 in 3 students is overweight or obese, with childhood obesity affecting at least 39% of children. This trend contributes to early onset diabetes and hypertension, made worse by limited access to healthy foods and safe places for physical activity. Baltimore City has one of the highest asthma-related hospitalization rates in the country. The city's emergency department visit rate for asthma is 3 times the state average and the highest in Maryland. At least 20% of children in Baltimore have an asthma diagnosis, more than double the national prevalence of 9%, with many children lacking consistent access to medical care and living in conditions that exacerbate environmental triggers. And yet, in the face of these challenges, Baltimore's children, families, and communities continue to show incredible resilience, demonstrating strength, resourcefulness, and a deep commitment to their health and their communities. At Medicine, committed to working with our neighbors and community partners to address these disparities through comprehensive and culturally responsive care and sustainable neighborhood engagement. Thank you again for the opportunity to testify, and thank you for your ongoing commitment to improving child health outcomes and advancing equity for families across Baltimore City.
Thank you so much, Jasmine. Is there anybody else that would like to testify? All right, colleagues. Just want to welcome Councilman John Bullock. Welcome, sir. Do we have a motion to vote on Council Bill 25-0013?
Madam Chair, do we need to vote on the amendments first?
Madam Chair, there are amendments that need to be
Oh,
moved
have you
first.
shared the amendments? Yes, the amendments have been shared.
We haven't voted on them. We need to vote on those first.
Oh, do we have, thank you. Do we have a motion to move the amendments?
Are we voting on them as a package, all
Yes,
three
as a package.
packages?
Yep.
Okay, so moved.
Thank you. Motion by Councilwoman Odette Ramos. Do I have a second? Second. All right. All those in favor?
Aye.
Opposed? Okay. All right. Now we'll move the bill as amended. Yes, thank you. We'll move the bill as amended. Do I have a motion?
So moved.
Do I have a second? Second. All right. Porter, yes. Conway? Yes. Parker? Yes. Dorsey?
Yes.
Torrance? Absent. Bullock? Yes. Ramos? Yes. Great. We have 4 yes? 5 yes, 1 absent. 6? No, 5, because Torrance wasn't here. 6? 6, okay. We have 6 yes? All right, perfect. And 1 absent. All right, the motion has passed. The bill will be placed on second reader at the next council meeting. All right, now we're going to move into our next bill. Yes.
Thank you, Madam Chair. Before the University of Maryland folks walk out, I just want to say I was listening to the testimony prior to coming in here, and I wanted to say you guys did a great job with the young people, had a great opportunity to interact with your youth workers as well, and so you do a great job in terms of connecting the dots in terms of what health equity really is and also the opportunities. So I just want to give you your flowers while you were here. So thank you so much, and appreciate all the talk about the health suites as well. So thank you.
Perfect. All right, we'll give a moment of transition. The committee will now begin the second hearing for the day for Council Bill 25-0035, gas-powered debris removal equipment, prohibition and enforcement, for the purpose of clarifying and conforming certain provisions related to the enforcement and prohibition of gas-powered debris removal and equipment. Councilman Dorsey, would you like to open us up for a remark, sir?
Yes, if I could take 30 seconds real quick. I'm trying to pull up a document real quick so I can be effective at this. Thank you, Madam Chair. This bill is essentially a technical fix to the bill that was passed last term to actually enable the law to be applied and upheld. There were a couple of oversights that presented practical and legal barriers that I think we had discussed with agencies when putting the bill together and when hearing the bill, but that were inadvertently missed in the draft and the execution of things. And so this bill fixes, I would say, 3 different things. One is it's absolutely impractical to expect that when a person who would want to report the illegal use of a leaf blower, gas-powered leaf blower that is, when a person wants to report it, it's being used right there, wherever they are right then. It's not reasonable to expect that the health department is going to have somebody materialize at that location in the next 10 or 15 minutes every time somebody witnesses such a thing. And so the law accounted for this by allowing for citizens to submit a report and photographic evidence of the violation and an affidavit that they witnessed this and that enforcement action can be taken on that basis. But mention specifically of the affidavit was omitted, and on further discussion thought it should be included in the bill text to be very specific about something that is required and that should be put forth in rules and regulations as to what exactly it looks like. And then further,
while the bill is structured to say, well, the law is structured to say that we issue an initial cease and desist as opposed to a fine for violation of the law, the law as we passed it authorized that issuance of a violation on the basis of photographic evidence and the report and such, but failed to include the issuance of the cease and desist being able to be issued on that same basis. And so we will basically never be able to get to issuance of a violation if even the cease and desist is dependent on whether or not some health department official has to show up at the exact moment and firsthand witness the violation. So even the cease and desist needs to also be issued or allowed to be issued on the basis of the complaint, photo evidence, and affidavit to that effect. And so this fixes that, and and then there was an omission in the course of the original bill hearing and passage. We had discussed how the bill was originally drafted to have civil and criminal penalties, which I think was really an error in the first place. It was intended to be environmental or civil enforcement. And then in the course of kind of looking at, wait a minute, we don't intend for this to be a criminal offense, we address that, but not the omission of environmental enforcement. And so this adds in the ability to enforce as an environmental citation and puts the appropriate penalties in the various places in the code where it needs to go. So again, all of this is stuff that essentially was just overlooked technical aspects of the previously passed bill. So we're just basically correcting this so that we can actually uphold the law. Thank you, Madam Chair.
Thank you. We'll now hear from representatives from our city agencies and then have an opportunity for committee members to ask questions. We'll first start with the city solicitor.
Thank you, Madam Chair. Michelle Toth on behalf of the City Solicitor's Office. We approve for form and legal sufficiency with 2 required amendments, which really just clarify and make the bill more cohesive internally.
Okay, Department of Finance.
Good morning, Gabriel Stewart-Sikowitz with the Department of Finance. We do not oppose the legislation as written or as amended.
Great. Department of Health.
Good morning, Madam Chair and members of the committee. My name is Jessica Speaker, and I serve as the Assistant Commissioner for Environmental Health. Health stands by our agency report. You will see that we have recommended favorable with amendments. Those are the amendments that the Law Department just mentioned. I'm happy to answer any questions if you have any.
Thank you. And last but certainly not least, the Environmental Control Board.
Good morning. I'm Brittany Vendries. I'm the Executive Director of the Environmental Control Board. We did not have a recommendation. This makes very little impact with regard to my agency. So,
great. I'm going to open up the floor to committee members for questions. Anybody have any questions? Yes, ma'am. Councilwoman Ramos.
Thank you, Madam Chair. Question for the sponsor. Just to understand, just to clarify what we're doing here. So the what will happen initially is that somebody will report to 311 that this happens, and then a notice basically goes out saying, hey, you can't do that. So then if they continue that, then they will get the citation. Is that basically what we're saying here?
That's correct. An initial contact to a person who is, observed to be violating this law will be a cease and desist. That really ensures that everybody has fair, individualized notice that this law even exists in the first place. We can pass laws here, doesn't mean that everybody is fully aware of them. So this cease and desist makes sure that they know it, and then if they do it again, we can issue a violation.
Which
and a
is the
fine.
typical way we do things anyway, in terms of like, if somebody's got high grass and weeds, we send them a violation notice, they don't cure it, then they get, a citation. So it's consistent with what the general practice is.
Well, actually, high grass and weeds, we typically just issue a citation for, I think, $50.
That's not the case for a vacant building, right?
Right
We
off the
give
bat,
a
but yeah, with
notice.
other things, yeah.
Yeah. Yep, okay, thanks.
Yes, Councilman Parker? I'm sorry, Councilman Conway. Mark and Mark.
Mark and Mark can always mix it up. It's a good name. I just wanted to clarify in these instances when we issue that warning to someone that is not tied to the property, it's tied to the person who committed the violation. Let's say it's a landscaping company working on a given property and they go to another property using that same equipment. Would it be tied to the landscaping company or is it tied to the property?
It's tied to the property.
Got it.
That's the other thing thank you for bringing this up.
Okay.
That's the other practical difficulty that this bill corrects that was always anticipated in the previous bill. If I'm a landscaper and I'm a dude with a white van and a white t-shirt, you have no idea who I am if you are just walking down the street on your street or any other street in the city, right? If you're on the opposite side of town from where you live and you see somebody violating this law, you should feel just as empowered to report that there as anywhere else. But you have no idea who that person is, and so your photographic evidence doesn't tell us anything like that, and we have no ability to enforce the law against a person unknown. And so being able to tie this to the property owner who hired that person or who bartered for that person to do it there or has that person doing it as a personal favor on their property, they need to know it's not acceptable for them, you, or anybody else to do this here or anywhere else in Baltimore City. And you're on notice to not let this happen and cause this to be happening on your property in the future.
Okay, thank you.
Thank you. Any other questions, colleagues? All right, we'll now move towards public testimony. All right, I don't believe we have anyone for public testimony. We're going to move to a vote. Is that correct, Councilman?
Madam Chair, as law mentioned, they said there are two amendments. They're mentioned as two amendments in their report, but they're consolidated into one amendment in the way that DLR drafted it.
Okay.
So I'll move the amendment from the Law Department.
Sure. Do I have a second? All those in favor, please say aye.
Aye.
Opposed? All right, now we'll move the bill as amendment. Do I have a motion?
So moved.
Thank you. That was moved by Dorsey, seconded by Torrance. Now we're going to go through for a vote. Porter, yes. Conway? Parker? Yes. Dorsey? Yes. Torrance? Bullock? Yes. Ramos? Yes. We have all yes. All right. The motion passed. The bill will be placed on second reader at the next council meeting. Thank you for everyone attending. This hearing is now adjourned.